Okay, so now we will discuss something regarding the problem in lie. So lie generally is longitudinal, but it's normal. We have oblique as well, but it's not worth discussing. So, but then we have transverse lie as well, which we need to discuss. So in transverse lie, if you see, this is the uterus, and this is, if I draw like this, of course this will be the posterior part and this will be the anterior part. So in transverse lie there can be two things that the babies can face. It can be basically two things. It can be dorso anterior or dorso posterior, means the dorsum of the body here is at posterior, or it can be the reverse one where the dorsum is at anterior. So most commonly what happens is, in transverse lie, the dorsum generally faces the anterior part. So the position is dorso anterior. That means the face is most of the time facing in the opposite direction. So dorso anterior is more common than dorso posterior. Now in transverse lie we can see that what is the denominator and what is the presenting part. So here my shoulder is the presenting part and the denominator is the acromion process. And position is of course dorso anterior more than dorso posterior. Draw it like this, it's DOA, it's DOP. So dorso anterior is more common. So moving forward, the causes is mainly placenta previa at term, but overall the most common cause is prematurity. Now what are the examination finding? On examination and during the first Leopold's maneuver, it will be empty. Okay, and in the pelvic grips 2 will be empty. So we can only see the lateral grip, in which we may found in one side we might find the head and one side we might find the legs. The fetal heart sound are palpable around the umbilicus and above. Moving forward, we need to know that what are the complications, main complications. Main complication is cord prolapse. Now how do we manage this case? This case is generally managed by external cephalic version or ECV. The two indications are one, transverse lie, and of course breech presentation. Then there are some prerequisites of doing external cephalic version. Then we will discuss about what external cephalic version is. First of all, there should be enough liquor to turn the baby. Then of course there should be it should be at term, because if it fails, we can directly go for a cesarean section. So the baby should be mature. Then the membranes should be intact. Up to latent phase of labor. That is according to the new WHO criterion, till the cervix is 5 centimeter dilated. Then we have, if it is a singleton pregnancy, fetal heart rate or cartogram is normal and no contraindication for vaginal delivery like placenta previa or contracted pelvis, cephaloperobic disproportion, etc. And the contraindications are just the opposite of each and every one of them. It doesn't require any further discussion. Moving forward, what is the procedure? The procedure is basically we have the transverse lie of the baby. So here what we do is basically under tocolytics like terbutaline without any anesthesia in the OPD itself, we per abdominally turn this into a cephalic presentation. So this is what basically external cephalic version refers to. So we do it under the influence of terbutaline, we do it in the OBT, and at the same times we do give an RH negative and anti-D injection if the mother is RH negative. And we do continuously fetal monitoring, so that if the baby's fetal heart rate increases or there is distress, we can immediately go for C-section. So mota the management is, if there is transverse lie, we first go for external cephalic version, most commonly at 37 weeks at term. If the first attempt fails, we retry on another date. If it is successful, we induce labor by oxytocin. If it is unsuccessful at the second attempt, then we go for elective cesarean at 39 weeks. Now if the first is successful, we just wait, we keep the mother under observation and routine care and wait for spontaneous onset of labor to deliver the baby vaginally.